Okay, so good afternoon, good morning, everyone. It's my pleasure to welcome everyone to this webinar. So this is the first in a series of webinars on urban health systems, chorus webinars on urban health systems. And in the webinar is part of a Chorus research program, and Chorus is a global research consortium that is working to make urban health systems more equitable and responsive to the needs of the urban poor. So Chorus brings together academic and research institutions from West Africa, Southeast Asia, and supported by a central team of research directors in University of Leeds and York, University of York, and a chief executive officer who is based in Ghana. So together we share a vision of cities where everyone, regardless of where they live or work, can access quality essential health services. And our theme today is from fragmentation to harmonization, strengthening urban health systems through provider partnerships and collaboration. So this theme actually speaks directly to our vision. We all know that across the world, cities are experiencing rapid expansion, and urban health systems are struggling to keep pace with the rate at which cities are growing. And in these in these cities, we have formal and informal providers working side by side, but not always together. And this is actually the reality of care for millions of people, and particularly the urban poor. So through this webinar series, we actually aim to open up conversation on how to build more resilient urban health systems that are more connected, that are stronger, that value collaboration, that value coordination, and mutual accountability from all providers. So in today's sessions, we're going to share findings from 4 cities where efforts have been made, innovative efforts have been made to strengthen partnerships between formal and informal providers, between private and public providers. And these experiences will remind us that it's important to improve health outcomes in urban areas, and that this is not just about resources that are provided, but it's about building relationships and building trust, and building a shared goal and purpose among providers across all levels of the health system. So I will encourage us as we begin to share insights, ask questions, reflect on how the lessons we're going to share resonate with you and in your own context. And this is a space for dialogue. The goal is for us to learn from one another and to think about how what we learn can shape more inclusive and resilient, responsive urban health systems in Africa and Southeast Asia and around the world. So thank you once again for joining us, and we very much look forward to the rich and inspiring discussions and insights that we'll have today. So I'm now then going to move on. Yeah, Bryony, or do I hand over? Okay. Yeah. So I think I'll just move on to present the findings from our cities. Yes, it's this. Okay. Okay. So Thanks. Just once again, just to introduce Chorus to us, for those of us who don't know about Chorus, it's a research program consortium, 6-year FCDO research program consortium. So we've been on since 2020. We have till 2022, and it's a collaboration of 7 organizations, as you will see, across 5 countries. So we've got Bangladesh, Ghana, Nepal, Nigeria, and the UK. And we're aiming to strengthen urban health systems for the urban poor. In Nigeria, Chorus is led by Professor Obinna Ujekwe. In Ghana, it's led by Dr. Genevieve Ariete. In Bangladesh, it's led by Professor Rumana and Professor Zahidul. And in HED, it's led by Dr. Sushil Baral. And then the central team, we have Professor Helen Elsie of University of York, Dr. Basi Benso, University of Leeds, and our CEO is Dr. Irene Ajiempong. So this just provides a visual overview of Chorus' approach to strengthening urban health systems. And at the base, you will see the principles that guide all our work. So the values and commitments that underpin every activity we undertake. And just above that, the foundations that also underpin our activities. So our foundations of capacity building, research uptake for impact, and management and governance of the RPC. And then building on these foundations are the 4 pillars of Chorus work. So we have linking across the plurality of providers, multi-sectoral collaboration, responding to the double burden of NCDs and CDs, and identifying and reaching and engaging the urban poor. And these pillars represent the main strategic areas of the work that we have been doing. And then surrounding these pillars are 5 key health system features that we focus on. So data quality, supervision, financing, regulation, and governance. Okay, so why is there such plurality, and what does it look like? So plurality of providers basically means that there are many different types of healthcare providers operating within the same healthcare system or area, and often offering overlapping or similar services. So what does plurality look like? It's a mix of public, private, informal, and formal providers that are delivering healthcare to the population. In Ghana, it would mean community health services, for example. In Nigeria, it would mean informal providers like patent medicine vendors, herbalists, traditional birth attendants. In Nepal, it means private formal providers. 92% of private formal providers, or rather 92% of providers are formal, 92% of providers are private providers, or formal providers are private providers. So this plurality we see can actually be a strength, it can be a challenge. Although there's increased access and choice for patients, the challenge is that there could be fragmentation, uneven quality, poor coordination, and weak regulation. So some providers are controlled by government, some are not, some are for profit, some are not. And all of these have implications for quality or access to quality care, particularly for the urban poor. From our situation analysis in the study sites, we have found that informal providers play a significant role in delivering healthcare to the urban poor, and they often fill the gaps that are left by the formal health system. So in slums in Southeast Nigeria, we found that approximately 60% of households were visiting informal providers as the primary source of care. And in Dhaka, Bangladesh, a mapping of providers in Dhaka showed that half were informal providers, and that these informal providers were clustered in low-income wards. It's often seen that the boundaries between formal and informal providers can be blurry, and the distinction is often unclear. So in Nigeria, for example, we have this quote from a community leader that some informal providers are actually people who have formal training experience, and even people who have even worked in the formal sector, but they are, for example, running chemist shops or patent medicine stores. Now, the work we have done in Nigeria, we have looked at strengthening linkages between formal and informal providers and the formal health system to improve access to quality healthcare for the urban poor. At baseline, we found that 9% of informal providers, only 9% actually had adequate knowledge of management of common non-communicable diseases, and it was similar too for the communicable diseases such as malaria and diarrheal diseases. We have intervened through capacity strengthening, through strengthening referral systems, or introducing a referral system, introducing a data reporting system, and providing supportive supervision, and strengthening formal sector or formal health system governance. And early findings from our evaluation of the intervention has shown some success with respect to effectiveness, findings that the overall quality of malaria case management has improved, though not statistically significant among informal providers. There's increased referrals from informal providers to the primary healthcare centers, and a reliance on informal-only providers by the community has also reduced by 86%, which is significant. And some sustainability measures with the establishment of an urban health unit, a governance system at the state level for linking informal providers to the formal health system. In Nepal, a system-wide intervention was co-created and implemented, linking pharmacies to primary care, and this aligns with the National Good Pharmacy Practice Guidelines that allows pharmacies to monitor blood pressure and counsel. So a package of intervention, including training, supervision, reporting, and referral, was introduced in Pokhara Metropolitan City, and early findings also show that there's improvement in reach, service quality, and client satisfaction. There's some improvement in awareness among clients on healthy behaviors. There's some improvement sorry, no, there's initial adoption. 11 out of 30 of the selected pharmacies and all 6 primary health facilities adopted the PEN protocol. And although it's not all, but it's some success. And most of the adopters among the pharmacies and all of the primary healthcare facilities demonstrated adherence to the PEN protocol with some adaptation of their referral practices. With respect to maintenance and sustainability, Pokhara Metropolitan City now has a budget for engagement with pharmacies, with private pharmacies. Then in Ghana, colleagues looked and are looking at the feasibility of introducing the Ghana's network of practice policy in urban settings. This has been successfully piloted in rural areas, and evidence from elsewhere, from Nigeria, from Zambia, and Indonesia actually shows that PHC provider networks are effective in reducing maternal and neonatal mortality and overall improvements in quality of care with some facilitators like referral system, peer-to-peer mentoring, collaborations, and MOUs. The challenge of replicating this in the urban setting is, again, the issue of plurality of providers, multiple providers. In the rural areas, there's a district hospital, a hub, and then all of these other primary care providers can be linked to the hub. In the urban areas, it's a bit more challenging. Then colleagues in Bangladesh, AK and BRAC, have also looked at policy response with respect to strategic purchasing. And that's about linking resources to quality, efficiency, and equity in service outcomes delivered. And early findings show that there's a current focus on specifying tasks. So basically, that purchasing isn't strategic. Resources are not allocated effectively. Quality monitoring is poor. There's some power dynamics between the Ministry of Health and Family Welfare and the Ministry of Local Government and Rural Development cooperatives. There's a lack of intention among LGAs to prioritize health services and enhance, and this is enhanced by over-reliance on foreign aid. I mean, with limited health budgets, this is what happens. So there's a need to formalize procurement process, limit and enhance production of reliable data on urban population health needs and strengthen accountability. So just showing how policy response can also not be aligned enough to support integration of formal and informal sector or the plural providers. So in summary, we can't ignore plurality. It's come to stay. And we can't only focus on the public sector as an option. We need system-wide responses. We need to train private, formal and informal providers. We need to strengthen governance systems. We need to strengthen health information systems. We need to strengthen community-level governance and accountability. And there's a need for implementation research to identify effective system-wide solutions, leveraging community engagement leveraging district and local government systems, data systems, and strengthening reporting, referral from informal to formal, and feedback mechanisms that will ensure patient-centered care. So these are some references. So some of our work we have published, findings from our work. Some are in the works, so we have included some of our references here. And I think I'm going to stop now and hand this back over to Bryony or Helen. Thank you.
Thanks, Chinyere, and hi, Brownie. Shall I just go ahead? Thank you. And thank you, Chinyere. That was just a fantastic overview. So I'm Helen Elsey, based at the University of York, and one of the research directors for Chorus. So it's just so exciting to see the findings coming out from the Chorus teams and the projects that we've been running over the last 4 or 5 years. So great to be able to share those findings. But for the second half of our webinar, I'm really delighted to say that we have some esteemed panel members, all bringing a wealth of experience and insight onto this issue about the plurality of providers within urban spaces. So the remaining half of our webinar will be having a panel discussion on some of the issues raised by the Chorus findings, and really trying to draw on our experts for advice and insights on the way forward. So let me go ahead and introduce our panel members. So first of all, we have Dr. Khalida Islam. So Khalida is the retired director of primary healthcare in Bangladesh, in the Ministry of Health and Family Welfare. She is currently on this strategic and technical advisory group for NCDs with WHO in Geneva. And she has a wealth of experience in health policy planning, and particularly around health systems strengthening. She has a real focus on NCDs, non-communicable diseases, aging care, emergency response for disasters. So welcome, Khalida. Thank you very much for joining our panel. Secondly, I'd like to introduce Mr. Subhash Bashtola from Nepal. So Subhash, hi Subhash. Subhash is the public health officer at the health division in Pokhara Metropolitan City. And he oversees the division's programs across all the wards of Pokhara and tracks performance and results. He's also the designated focal person for non-communicable diseases and mental health, and serves as the acting chief for approvals and decision-making whenever needed. So more than 9 years experience in the government sector, especially in policy process, drafting and finalizing official documents. So welcome, Subhash. Thank you so much for joining our panel. And next, I'd like to introduce Emmanuel Ikedichukwu Ayugu from Enugu State PMC Development Agency in Nigeria. So welcome, Emmanuel. Great to see you there. So yeah, Emmanuel is a licensed medical social worker, over 5 years experience in social work practice, and currently working with the Enugu State Primary Healthcare Development Agency. So a really strong background in social work and health promotion and communication. So welcome. Thank you, Ikedichukwu, for joining us as well on the panel. And last but by no means least, Dr. Andrew Zayim from Ghana Health Service. So Andrews is the Deputy Director of Public Health in Bono East Region, Ghana. As a public health specialist, and his job really entails ensuring the development of Ghana Health Service strategic policies and plans to continue the development of national health policies. He's a leader in the training and dissemination of the community scorecard, which I'm sure many of you are familiar with from the community health and the CHIPS program, and has really played a really central role in the work on CHIPS in Ghana. So welcome, Dr. Andrews. Brilliant to have you with us. So yeah, thank you everybody for joining. So we just have a number of questions and which tie into some of the findings that that Chinyere presented to us from all the chorus work. So first of all, Emmanuel, maybe I can turn to you, and really we've seen this sort of limited provision of public primary care in cities with rapidly growing populations. And obviously there's this drive for universal health coverage. But could you tell us more about the informal providers? Do you see them as part of the problem or part of the solution to try and improving the health of people, particularly in informal settlements and low-income households? Yeah, please give us your insights.
All right, thank you for having me. I believe you're hearing me loud.
Perfectly.
I'm from Enugu State Primary Healthcare Development Agency. Yeah, I believe the informal health providers, to a great extent, are the solution. If all things being equal, I mean is if there are proper guide and proper supervision in their activities in the urban slum, of course, they go a long way to profile health solution to the urban dwellers in their slums.
Yeah, thank you. And I think we've seen that coming out, particularly the findings from the work of Chinyere's team at HPRG, looking at the role of informal providers, really increasing people's access to public services as well as through the informal providers. So yeah, thank you for that. Dr. Khalida, how about from the Bangladesh perspective? How can informal providers be helped to sort of improve their quality and be part of this wider system?
Thank you so much for having me. Currently, it is a strength, the informal providers. However, this strength is based on a very weak foundation because there are lots of problems. And as for example, we don't know the exact definition of informal providers for Bangladesh because we don't have any idea how many of them are working in the cities. What are their categories? What are their trainings? And especially, what is the quality of service they are providing? And moreover, with changing epidemiology, if we can train them and orient them with our healthcare provision and the recent problems, like Bangladesh is the worst sufferer of climate change. So there is flash flood, political instability giving rise to mob violence, man-made disaster like building collapse, huge building collapse, and then accidents like gas cylinder burn, fire hazard, and electrical burn, etc. We are not getting these frontline health workers or healthcare providers, informal caregivers in this sector. If we, with some training, with some orientation, if we can train them as first responder, that will add a huge support to our urban healthcare. If they know what to do, where to refer, whom to refer, that will be a great help. Thank you.
Yeah, thank you, Dr. Khalida. I think really interesting to see them as the first responders at community level and that key role in referral. And I think we saw that that can happen. That role in referral is very much a reality in the work that the team have been doing in Enugu. So really valuable to see that. Maybe Subhash, I can see your camera on. So maybe the next question to you, because the study in Nepal really showed a lot of people using pharmacies. This is really a popular place for people to go for a whole range of health issues. Maybe could you share your experience about working with pharmacies and trying to improve the quality yeah, any insights from Pokhara?
Thank you, Helen. First of all, I would like to share some background content regarding this question. The burden of the disease in the urban setting, especially in the Nepal's major cities, is huge. We can share some fact as well. We are facing now triple burden of disease, especially in the urban areas, particularly NCDs, non-communicable disease, sometimes communicable disease, and the road traffic accidents and injuries as well. And according to the burden of disease survey conducted in 2019, around 70% of the total death is due to from the NCDs in Nepal, and around 60% lost from the NCDs. Similarly, the pocket expenditure is also high. It's around 54% in Nepal. It means we are pushing the people in poverty due to the healthcare expenditure as well in Nepal. The population composition, especially urban population, is also growing in Nepal. Around 27% of population is totally in urban areas, whereas 40% is in peri-urban areas. Regarding the questions you mentioned earlier, the quality context of these different pharmacies, medicals, and clinics in Nepal is some studies shows that there are low compliance score in quality, around 11% only in quality compliance score, whereas the highest compliance score is in procurement section. It means there is huge room for improvement in the quality concern. Beyond this fact, I observe while I supervise and monitoring them, some pharmacists practice polypharmacies and some irrational drug use in some urban areas still. And some of the positive aspect as well, they have been practicing in our areas. We observe actually in our visit. They are very easily accessible to the people in near to the community. Similarly, they have long out to open, but they dispense sometimes medicines without prescription as well. These are the some areas we need to improve to reduce the negative impact of these types of the practice in urban setting. To link this pharmacies clinic in wider health systems, some steps, some activities we can adopt. Some of them are we can just regulate them continuously with the different tier of government, with the coordination of different tier of government. We have 3 tiers of government in Nepal, and we are currently in the local level of government right now. And another one is we can provide some trainings to enhance their capacity for the screening, counseling, refer mechanism, and also for the standard treatment protocol. We observe some gap in the practice of the private providers and the government service providers. So uniformity is also the one of the area to improve here. And another one is we can integrate their patient health information through the digital integration. We commonly can share the common platform to incorporate, to gather, and to analyze the data from the private sectors as well, especially from the pharmacies. And I can share some success stories regarding this question. And before these areas, I worked in the one of the major cities of the Nepal, and we started some data integration program from the private clinics, especially in the family planning. Later, this really helps to increase the contraceptive prevalence rate in that particular area. And that was one of the lesson we gained. And now with the coordination of the some organization, Hard International recently collabed here in the Pokhara metropolitan city, and they also piloted some of the intervention here, and the result was fantastic. And we are happy to share that we allocate budget to scale this program through our government sector this in this financial year. And having said that, there are some challenges I observed and I faced in these conditions. One of the biggest challenges is policy and legislative barriers, because the local government do not have right to regulate directly, especially pharmacies, but we do have some authorities to regulate the different medicals, polyclinics, and even up to 15 bedded hospitals. But we don't have any regulative authority for the pharmacies, and we have to make some policies to regulate closely. Maybe inefficient recording and reporting system. Many private providers do not have any practices to record and report in the higher centers in Nepal. Third one, maybe there is no any health information system currently running in the pharmacies and medicals. They provide services in the community, and if we integrate with them, we have to initiate from the beginning, and it's also challenging. And lastly, the major challenge is financial challenge, that we have to integrate them through the digital platform, and we have to provide some training, and all these interventions need the budget, and it's a major challenge. And also the one of the not that important challenge, but I felt the conflict of interest as well, because the private providers are definitely concerned with the profit motives rather than the service motive, and this one also can create great challenge to develop and implement the program here in Nepal, especially in the urban area. Thank you.
Yeah. Thank you, Subhash. That was a brilliant overview of so many of the issues, from the sort of data integration, the challenges of regulation, and the policy to support that, as well as obviously the motivation and the fact that pharmacies, or all of these providers we're talking about, are businesses, and they need to make money. I wondered, Dr. Ayim, could we turn to you, and from the Ghana perspective? I know you're in Ghana, you're looking at sort of networks of practice and the way to bring in all these different providers. But any reflections in terms of some of the challenges Subhash was mentioning around regulation and making these connections?
Okay, thank you so much. I think Ghana had been lucky because we had already started the community-based health planning and services concept. But then when we come to the urban area, the definition of a community was where the challenge came, because the fragmentation of the urban area communities, it could be settlers, it could be migrants, and even those who stay in various places travel to other places to work in the day and send their children to school at other places. So that when you mention community, is it where the people go to school? Is it where they go to work? Is it where they stay? And those are the places we were chasing with services at the community level. Then the other thing we noticed was also that the facilities that are built in the urban areas were huge facilities that culturally were not accessible to the low income groups, because even the dress to wear to a hospital itself could be a deterrent to that lower group. And land availability to build chips in the urban areas was more difficult. So we were using containers to which could be removed anytime. So the community, it was more acceptable to the communities. And we used that. So we decided to link them up. But the key challenge, like he said, was the policy challenge of transforming the sub-district structures to promote leadership in a network arrangement, because it was all solo arrangements. But we were happy that the National Health Insurance Authority had already accredited a lot of the pharmacies. The Pharmacy Council had already introduced e-pharmacy to a lot of them. And also the Health Regulatory and Facility Authority is registering the facilities. And so one of the criteria was data requirement, data sharing requirements and all that. So we brought all this in. So when you look at the design of our network of practice, you will see that underneath it are the regulatory systems that we are using to bring people together and make the relationships better, so that the relationships are mandated by the Health Regulatory Authority, the National Health Insurance, and all that, so that clients can go there. So these are the advantages that we've had to deal with. But now the issue is the supervisory roles of the various levels of the healthcare. For instance, a regional hospital supervising a pharmacy shop in the network. So now we are creating network phenomenon where they would keep meeting, and some of the issues which were the non-profit commodities like immunization, a lot of them want to use it to promote the people who would attend their facilities. So we are using those we are leveraging on those ones, immunizations, placing community health nurses in some of those private facilities to support them in immunization and other things that don't give them profit. And because they are happy with that, then some of them are coming to terms with us and even negotiating with us to reduce some of their costs, because then our clients increase when we all come together. So this is the Ghana's experience in the network, and we are using regulatory network, facility network, and service networks also to promote the efficiency in the urban areas. Thank you.
Thank you, Dr. Yim. And I think really interesting to hear how you've got those sort of three aspects, including regulation, but also ways to try to motivate the private sector to get involved. And I think that's certainly something that's come out of some of the chorus work, is that the private providers, the informal providers, there's always this key motivation to also to have like good standing in their community, and that's how they get customers. So providing good care is good for business. And I think that sometimes we can be very put off by the idea of the profit motivation, but actually there's other motivations in there that I think we can draw on, can't we, to make sure that to build these linkages. Yeah, I wonder, Ikedichukwu, do you want to add anything more about from the context in Enugu, how you can manage to get informal providers really motivated to refer to the public sector or to provide? We've heard about the challenges of reporting and regulation. How in your context, how do you motivate the informal providers to be part of that system?
All right, thank you once again. There is already existing relationship between the informal health providers and formal health providers through the linkage. We, as desk officer in the Enugu State Primary Healthcare Development Agency, we have established a relationship between the formal health care providers and informal healthcare providers. And of course, the linkage system have been strengthened. The reports already out there, the people seeking healthcare no longer have this inferiority and inferiority complex such the same going to the formal health providers. Now, the informal health providers on their own side are now seeing that the government coming into to recognize what they are doing is not actually policing them, but to strengthen healthcare services. So when we go for supportive supervision, we encourage them to do the limit they can and make referrals where possible. We have equally engaged the community leaders to be part of the system where the community leaders now know what the informal health providers in the urban slum are doing and at what point they make referral to formal health providers. So in a nutshell, the linkage system have been strengthened and we encourage to do more. Like, you know, in urban health, in urban slums, the informal health providers keeps coming in. So we're going to educate them on the system and link them equally to the system. And it's working perfectly as we speak, as we continue to introduce new informal health providers in. That's it. And of course, we are working to make sure that the government strengthen this urban health unit. As we speak, we are working to make sure that the urban health unit is included in the health plan of the ministry. When that is done, it will be the activities of urban health unit will be included in the annual operational plan and of course budgeting. When this happens, we are optimistic that there will be sustainability in the system and it will continue to flow.
Yeah, thank you, Ikedichukwu. That's absolutely key. And I think Subhash mentioned a similar thing, that these kinds of approaches, you know, they're getting into the plans and budgets, which is, you know, if we want sustainability, that's fantastic to see in the public sector really taking that on and grappling with this issue. In the presentation, so Khalida, one for you. In the presentation, Chinyere was referring to the work around strategic purchasing that I know that has been going on in Bangladesh. And I wondered if you could say a bit about what you think it would take to really make this transition from kind of very passive purchasing of services by the public sector to being much more strategic and thinking about the population need, the quality of services. Yeah, what needs to happen to make that happen?
Thank you so much. Actually, for last couple of months, maybe last 1 or 2 years as well, we are seriously considering to involve all the providers in urban area through strategic purchasing, and lots of workshop, brainstorming sessions, data collections were going on to get the idea how we can do best of strategic purchasing. So what we felt that we need to do a clear outline of service provision. What service should be provided, who will be provided, how much will be provided, and what will be the cost. We need to define that and then develop a more tool or instrument for governance so that the strategic purchasing will be under very good governing body and will be governed properly. And then 2 more things I would like to emphasize for specifically for Bangladesh context, that is adoption of national protocol for primary healthcare system, which are existing. We want the strategic purchasing will be emphasizing implementation of that national protocols for primary healthcare setting. As for example, in Bangladesh, the Kuras, they are implementing this national protocol, which is the government has developed for control management of hypertension and diabetic. It is implemented in urban setting. So the floating people, the migrating population, wherever they go, they will be receiving the same treatment. They will be receiving some subsidized medicine from the government sector if they are, if we can do this strategic purchasing. And last, most important point is emphasizing on essential service package. The government need to do a detailed mapping of the service providers. Who are there? What is their capacity? Based on their capacity, the government should identify from the essential service package which portion should be given to which category of providers, and all the services of essential service package should be allocated to somebody, any of the organizations, so that any people from the community can go to some place to get to get each and every component of service which is included in the essential service package. So all the, as for example, in the last sector program, we emphasized on maternal and child health care in urban population, and almost no private facilities like NGO facilities or others. They were providing non-communicable disease care. So we have to include all the services of essential service package and go for strategic purchasing. And we have to introduce regular monitoring and supervision. We have to, as my all other colleagues mentioned, data capturing, electronic database, and organize coordination mechanism. And one most important thing is policy document. Like we have our urban health strategy developed in 2022, it is 5 years gone, which needs to be updated. And this strategic purchasing has to be included in this strategy, and detailed modalities should be mentioned. These are the few steps which is important for Bangladesh context for strategic purchasing. Thank you.
Thank you so much, Dr. Khalida. And I think it's really valuable for other countries and policymakers to hear about the work that's happening in Bangladesh towards policy moves like strategic purchasing. So really, really good to have that. And I know the ARC and the JPG, James P. Grant School of Public Health in Bangladesh are pulling together findings around strategic purchasing now. So please do watch this space, and you will see in the chat that lots of different resources from across the Chorus team have been added there. So please do follow those up and take a deep dive into some of the research that all the brilliant Chorus partners have been doing. So we are now at the hour. So I have to say a big thank you to our panelists. Thank you very much for your insights. We've covered a huge range of issues and in different contexts, but incredibly some real similarities in terms of the challenges of working with such a wide variety of private, informal, formal providers. And it's just really fascinating to hear some of the strategies and the increased sort of focus within city governments and local level governments to really take on this issue and tackle it head on. So thank you so much for joining our Chorus panel. We really appreciate your time. Yeah, thank you to everybody for listening. But before you go, I do want to just highlight that we have a couple of other webinars coming up, and non-communicable diseases was a theme that was emerging in that discussion. So you'll be pleased to hear that the next webinar in November, we think the 13th of November to coincide with World Diabetes Day, will be on urbanization and non-communicable diseases, sharing findings from the Chorus work in that area. And then in December, the 11th of December, we'll be looking at issues around who gets left behind, the most vulnerable people, households and communities in cities, and the strategies and ways to engage with them and to try to have more equitable responses to health in cities. So a big thank you to everyone for your time. Thank you for joining us, and we really hope that you join us for the next webinar, and please do have a look at all those chorus publications. And yeah, thank you for your participation and your time.
Thank you so much.
Thank you. Thank you
Thanks
so much.
everybody.